Welcome to the deep dive. Today, we're diving into a really important topic in pediatric health, retinoblastoma.
Yeah, definitely crucial.
If you're involved in caring for kids or, just want to understand some of the more significant childhood conditions, this one's for you.
Absolutely. Retinoblastoma, sometimes just called ARB, it's a rare eye cancer, but it develops in early childhood.
Okay.
And it's actually the most common malignancy of the eye in this age group. So yeah, understanding the key points is really vital.
Right. Okay, so let's unpack this then. What exactly are we talking about when we say retinoblastoma?
Well, basically, it's uncontrolled growth. You've got these immature cells in the retina.
That's the light-sensitive bit at the back of the eye.
Exactly, the light-sensitive tissue. And these cells, instead of, maturing like they should, they just multiply and form a tumor.
Okay. And when does this usually happen?
It can technically start really early, like from the third month of pregnancy up to about age 5.
Wow.
But the average age when it's actually diagnosed is around 18 months.
18 months. So most kids are diagnosed before they're even 2.
That's right. Think about that. Very young.
And what's driving this? What's the underlying cause of this uncontrolled growth?
So the main driver is genetic. It's mutations in a specific gene called RB1.
RB1.
Yeah, this gene normally helps regulate how cells grow and divide. And in about 40% of retinoblastoma cases, there's a hereditary link,
40%.
meaning a mutation in that RB1 gene was actually passed down from a parent.
Okay, hereditary. That sounds like it could have wider implications then. Let's dig into the why a bit more.
Right. So as we said, the root cause is these genetic mutations in RB1.
Uh-huh.
What's interesting is how they happen. There are kind of two main routes, inherited and non-inherited, or what we call sporadic cases.
Okay.
In the inherited ones, a child gets one mutated copy of the RB1 gene from a parent. So they're kind of starting out with one faulty copy, if you like.
Right, like one strike against them already.
Exactly. Then, in the sporadic cases, which make up the other, say, 60%, mutations happen spontaneously in both copies of the RB1 gene.
Both copies.
Yeah, in just a single retinal cell during early development. It's like a random error happening at the cellular level early on.
Okay. So if a child inherits this mutation, are there other risks, other things we should be aware of?
Yeah, definitely. The biggest single risk factor for getting retinoblastoma is having one of those inherited RB1 mutations.
Makes sense.
And because of that genetic link, it nearly always affects young children, most diagnosed before age 5.
Right.
But here's something really important. Hereditary retinoblastoma, the inherited kind, also increases the risk of developing other cancers later in life.
Oh, really? Outside the eye.
Yes, outside the eye. We're talking things like Ewing sarcoma, olfactory neuroblastoma, osteosarcoma, and other soft tissue and bone sarcomas.
Wow.
And unfortunately, that increased risk can stick around for many, many years.
That really highlights the significance of that genetic link. So, okay, how does this RB1 gene work normally? And what exactly goes wrong in retinoblastoma?
Okay, think of the RB1 gene as like a traffic controller for cells in the eye.
A traffic controller.
Yeah, it makes a protein that basically tells cells when to grow and, crucially, when to stop dividing.
Right, the brakes, sort of.
Exactly, the brakes. In retinoblastoma, mutations damage or disable this controller, these brakes. So without that proper regulation, the immature retinal cells just multiply without any checks, without any balances.
And that leads to the tumor.
That leads to the tumor forming. And these tumors can then invade nearby tissues inside the eye, and sometimes, in more advanced stages, they can spread, metastasis.
Right, metastasis. And you mentioned needing mutations in both copies, both alleles of the RB1 gene. Can you elaborate on that a bit?
Sure. So we all get 2 copies, or alleles, of pretty much every gene, right? One from each parent. For retinoblastoma to actually develop, both RB1 alleles in a single retinal cell need to stop working properly. They both need to be mutated or lost.
Okay, both copies need to fail.
Exactly. So in the hereditary form, the person is born with one non-working copy already. That's the germline mutation. It's in all their cells.
Right.
Then, sometime during early life, the other working copy in one or more of their retinal cells gets hit by a spontaneous mutation. That's the somatic mutation, the second hit.
The second hit, okay.
And that second hit knocks out all the RB1 function in that specific cell or cells, leading to the uncontrolled growth.
Got it.
What's interesting, though, is if you carry that hereditary RB1 mutation, you have about a 90% chance of developing retinoblastoma.
90%, that's high.
It is high, but there's only a 50% chance you'll pass that mutation on to your child. And weirdly, about 10% of people who carry the mutation never actually develop the condition.
Huh. Incomplete penetrance, is that what it's called?
Exactly, incomplete penetrance. We describe this hereditary form as having autosomal dominant susceptibility. Inheriting one bad copy massively raises the risk.
Right. And the non-heritable form.
In the non-heritable form, both mutations happen spontaneously, just by chance, within the retinal cells of someone with no family history. Two separate bad luck events in the same cell lineage.
What?
And importantly, if that non-heritable form is caught and cured, the person usually has a normal life expectancy.
That's good to know. It's like you said, needing two flat tires. Inherited means you start with one already flat.
Precisely. Makes getting that second flat, that second hit, much more likely to cause trouble.
Okay, so let's shift gears slightly. If a young child comes in with, say, an unusual eye symptom, especially that white reflection you hear about, what else could it be? What's on the differential diagnosis list?
That's a really critical question for anyone seeing kids. When you see leukochuria, that classic white pupil reflex retinoblastoma is definitely high on the list, but it's not the only thing. A big one is congenital cataract, where the lens is cloudy from birth.
Okay.
Another possibility is toxicariasis. That's an infection from roundworm larvae, believe it or not, which can cause inflammation inside the eye, endophthalmitis.
Wow. Yeah.
And in girls specifically, you might think about incontinentia pigmenti, which is a genetic thing affecting skin, eyes, other tissues.
What about actual growths?
Good point. If you're seeing something that looks like a growth inside the eye, what we call an endophytic tumor, you might consider retinal hamartomas, benign growths.
Okay.
And if the growth seems to be on the outer surface, exophytic, then maybe choroiditis inflammation of the choroid layer.
So quite a few possibilities just for that white reflex or a visible growth. Are there other specific conditions doctors need to rule out?
Yes, definitely a few more important ones to keep in mind. There's something called persistent hyperplastic, primary vitreous, or PHPV.
PHPV.
Yeah, basically blood vessels from development in the eye that didn't disappear like they should. Then there's Coates disease.
Coates disease.
That involves abnormal retinal blood vessels leaking fluid, which can cause retinal detachment, usually just in one eye.
Okay.
For premature babies, advanced retinopathy of prematurity, ROP, can sometimes look similar in severe cases with retinal detachment.
Right, ROP.
Also, retinal dysplasia, abnormal retinal development, either on its own or with other systemic issues. And finally, retinal astrocytoma, which is actually a benign tumor of the retina, but it can look concerning.
Okay, so a broad differential. Good to remember, it's not always retinoblastoma. What about how common this actually is? Let's talk epidemiology.
Sure. In the UK, it's rare. We're talking about one case in every 15,000 to 20,000 live births.
Okay, quite rare then.
Yeah. It makes up about 3% of all childhood cancers. And interestingly, there's no real variation across different ethnic groups. Everyone seems equally susceptible. We see around 40 to 50 new cases diagnosed each year in the UK.
40 to 50 a year.
Yeah. And remember that timing, about 40% are diagnosed in the first year of life. It really drops off after age 5.
Matches that developmental window you mentioned?
Exactly. About 60% of cases affect just one eye unilateral. And around 40% are heritable, often affecting both eyes, bilateral.
Okay, 60-40 split roughly.
Yeah. And there's a small subset, about 4% of the heritable cases, who develop something called trilateral retinoblastoma.
Trilateral.
Yeah, tumors in both eyes, plus a related tumor in the pineal gland in the brain called a paraneoblastoma.
Wow, okay. Brain involvement too in some cases.
Yeah.
So what are the key things, the warning signs that parents or doctors might notice? The clinical features.
The absolute classic sign, the one everyone needs to know, is leukochuria.
Leukochuria, the white reflex.
Exactly. That white reflection in the pupil, sometimes people notice it in flash photos, looks like a cat's eye. That's number one.
Okay, what else?
Another common one is strabismus, a squint, basically, where the eyes look crossed or misaligned.
Right, the squint.
Parents might also notice the child just doesn't seem to see well out of one or both eyes. Poor vision. Or the eye might look red or irritated quite often. Sometimes kids might start squinting more or have kind of jiggly or abnormal eye movements as they try to focus.
Trying to compensate.
Exactly. And then during an exam, if the doctor doesn't see the normal red reflex with their ophthalmoscope, but sees that white leukochuria instead, that's a major red flag.
So absence of the red reflex is key too.
Absolutely. And just generally, any visual problems reported in a young child need checking out seriously.
Okay, so if retinoblastoma is suspected, based on those signs, what happens next? What investigations are done?
Right. The absolute cornerstone is a detailed eye exam by an ophthalmologist.
Specialist exam.
Yes, using an ophthalmoscope to get a direct look at the retina, check for tumors, then imaging is crucial.
Like scans.
Exactly. Ultrasound of the eye, MRI, sometimes CT scans. These help see the tumor size, where exactly it is, and critically, whether it's spread outside the eye itself.
Okay.
And genetic testing. Testing for those RB1 gene mutations is really important.
Why is that so key?
Well, it helps figure out if it's a hereditary case or a sporadic one. And that has massive implications, right, for the child's risk of other cancers later on, and also potentially for siblings or future children.
Right, the family implications.
Absolutely. Often, for a really definitive diagnosis and assessment, the child will need an examination under anesthetic.
Under anesthetic.
Yeah, so they're completely still, pupils dilated, allows the ophthalmologist to get a really thorough look at the entire retina.
Makes sense for little kids.
And things like bidimensional ocular ultrasound and MRI are particularly good for checking if there's any spread beyond the eye, and also for helping differentiate ARB from those other causes of leukochuria we talked about.
Right.
If there's any suspicion the tumor might have spread further, then other tests might be needed to look for metastatic disease elsewhere in the body.
Right.
And as we've kind of touched on, genetic counseling is really strongly recommended for all patients and their families, regardless of whether a mutation is found initially.
Okay, so genetic counseling is standard. So once it's diagnosed, what's the management plan look like? It sounds like it has to be very individual.
It absolutely is. Highly personalized. The treatment really depends on, how big the tumor is, where it is, how many tumors there are, the stage of the disease, and also the child's general health.
Right.
The good news, the really positive message, is that removing the eye enucleation isn't the only option anymore. It used to be much more common.
Ah, that's good. So there are eye-saving treatments.
Yes, big time. Advances in early detection and these eye-conserving treatments have made a huge difference. Options now include things like chemotherapy, radiation therapy, cryotherapy, which is freezing the tumor, and laser therapy.
Lots of options.
Yeah. And then follow-up is absolutely critical. Regular surveillance to watch for any recurrence or new tumors popping up.
Constant monitoring.
Pretty much. And again, that genetic counseling piece is woven throughout the management, especially if it is a hereditary case.
Yeah. Just tell me more about these eye-conserving treatments. What do they actually involve? When are they used?
Sure. So photocoagulation uses a laser beam to basically heat up and destroy very small tumors. But it's usually not suitable if the tumor is right on the optic nerve or the macula, the central vision part.
Okay, for specific locations.
Right. Cryotherapy uses extreme cold, applied to the outside of the eye over the tumor, to freeze and kill small tumors, usually ones more towards the edges of the retina, the periphery.
Freezing it.
Yep. Then there's transpupillary thermotherapy, TTT. That uses infrared laser heat, but a gentler heat than photocoagulation, again for localized peripheral tumors.
More heat. Okay.
Plaque radiotherapy is another one. That involves stitching a small radioactive disc, like a little coin, onto the outside of the eye right over the tumor for a few days. Delivers localized radiation.
Targeted radiation.
Exactly. For small, single tumors, usually. Then you've got chemotherapy. Systemic chemo given by mouth or IV can shrink larger tumors, maybe make them suitable for laser or cryo or treat tiny bits of spread.
Right, systemic approach.
And there are more localized chemo approaches too. Periocular chemo involves injecting chemotherapy, like carboplatin, into the tissues around the eye.
Around the eye.
Yeah. And even more targeted is ophthalmic artery chemotherapy, or OAC.
OAC.
Where they thread a tiny catheter up through the arteries, right into the ophthalmic artery supplying the eye, and deliver chemo like melphalan directly to the tumor. Very high dose locally, less systemically.
Wow, that sounds precise.
It is. These eye-conserving treatments are generally for smaller tumors or used in combination, really pushing to avoid removing the eye whenever safely possible.
But sometimes removing the eye, enucleation, is still necessary.
Yes, unfortunately, sometimes it is the safest or only option. This might be for very large tumors in one eye, especially if tumor cells have spread into the vitreous gel inside the eye that's called vitreous seeding,
Okay.
or if there's extensive retinal detachment, or if abnormal blood vessels are growing on the iris, or just if the tumor has destroyed too much of the eye's structure.
Got it. What about external radiation, like beams of radiation? When does that come into play?
External beam radiotherapy, EBRT, it can be used sometimes, particularly for cases with tumors in both eyes, or very large tumors, or maybe significant vitreous seeding that hasn't responded to other things.
Cool.
But It comes with potential long-term side effects, things like cataracts, damage to the retina, or optic nerve later on.
Right.
And importantly, especially in kids with the heritable form of ARB, external radiation significantly increases the risk of those secondary cancers later in life. So it's generally avoided, if at all possible, in those heritable cases.
Okay, so a last resort, maybe, especially for the inherited type. What if the cancer has spread?
Yeah.
Disseminated disease.
If it's spread beyond the eye, treatment obviously needs to be more intensive, usually involves systemic chemotherapy, often platinum-based drugs.
Okay.
If it's spread to the central nervous system, the brain or spinal fluid, that needs CNS-directed therapy, sometimes including radiation to the brain and spine.
Right, more aggressive.
Yeah. And for more widespread metastatic disease to bones or elsewhere, it usually involves very intensive chemotherapy protocols.
Okay. And the follow-up you mentioned,
Yeah.
that must be incredibly rigorous.
Oh, absolutely crucial. Lifelong, really, in many cases. Regular follow-up appointments are essential to check for recurrence or new tumors.
How often?
The schedule varies a lot depending on the case, the treatment, the center, but it's frequent, especially early on. Siblings might also need screening exams, particularly if it's a heritable case or if the genetic situation isn't clear.
Right, screening siblings.
Yeah. And for individuals known to carry an RB1 mutation, there are specific guidelines for regular eye exams, often every few months in early childhood. Even if a child has unilateral RB and no mutation is found, they still need ongoing clinical exams because there's still a small chance of a mutation missed or mosaicism.
Okay.
If there are retinomas, these are like benign, spontaneously regressed or partially treated tumors, they still need monitoring.
So even benign ones need watching.
Yes, because they can sometimes reactivate. And because of that sarcoma risk in heritable cases, everyone needs lifelong awareness. Any lumps, bumps, bone pain needs prompt investigation.
Vigilance is key.
Absolutely. And remember that trilateral risk. Regular brain MRIs, often every 6 months for a while in suspected heritable cases, are usually done to screen for pineoblastoma and distinguish it from benign pineal cysts, which are common.
Okay, comprehensive follow-up. So what's the overall picture then? What's the prognosis for children diagnosed with retinoblastoma today?
Well, the really good news is that the prognosis in terms of survival is generally excellent in developed countries.
Excellent.
Yes, over 90% survival into adulthood, often quoted as high as 95–99% in places like the UK and US.
That's amazing progress.
It really is. Things like whether the tumor has invaded the optic nerve or its exact location can affect the outcome, particularly vision outcome, but survival rates have dramatically improved.
You mentioned UK rates improving.
Yeah, there is data showing 5-year survival went from about 86% back in the late 60s up to around 99% by the early 2000s. Huge jump.
Incredible. But what about vision?
That's a caveat. While survival is excellent, many survivors will have some level of visual impairment in the affected eye or eyes. It can range from moderate to severe.
Okay, so survival is high, but vision can be affected.
Exactly. And extraocular spread, cancer getting outside the eye, is thankfully now rare in developed countries because of early detection and effective treatment. If metastasis does happen, it can go to the brain, CNS, bones.
Right.
And we have to come back to the secondary cancer risk for the hereditary survivors.
The osteosarcomas and others.
Yes, particularly osteosarcoma. That risk is significantly increased even if they never had radiation. Sadly, these secondary tumors are a major cause of death later in life for survivors of hereditary RB, especially those who had bilateral disease.
So a long-term shadow for some. What are the other potential long-term complications survivors might face?
Well, beyond the secondary cancers, treatment itself can have consequences. Enucleation, removing the eye, can sometimes affect how the bones of the eye socket grow.
Orbital growth.
Yeah. Depending on the tumor location and treatment, there can be visual field defects. Visual acuity, as we said, is very variable in treated eyes.
Okay.
Certain chemo drugs, like carboplatin, carry a risk of hearing loss.
Hearing loss, too.
Yes, and then thinking prevention. For families with a known hereditary risk, prenatal testing is an option for future pregnancies.
Right.
And it's generally recommended that survivors, especially those with the heritable form, try to limit exposure to known DNA-damaging things, like smoking or excessive sun, to try and minimize that secondary cancer risk.
Makes sense.
So the main complications to summarize are potential vision loss, the rare but serious risk of metastasis if caught late, and that significant long-term risk of secondary malignancies, particularly after radiation, but also inherent in the hereditary form.
This has been incredibly thorough, a really fantastic deep dive into retinoblastoma. It's so clear that, understanding the genetics, spotting those early signs, and the treatment advances are all just vital.
Absolutely. The genetics piece is fundamental. Recognizing leukocoria, that white reflex, early is probably the single most important factor for a good outcome.
Yeah.
And the treatment progress means we save eyes and lives much more effectively now. But you're right, that secondary malignancy risk in hereditary cases is something that needs lifelong awareness and monitoring.
Definitely. If listeners want to consolidate this maybe for revision or just explore more, where should they look? Any recommendations?
Yeah, for sure. If you're revising for exams like the MSRA or just want solid medical resources, I'd definitely point you towards pastthemsra.com.
Pastthemsra.com.
And also check out freemsra.com for, well, free resources too. Both are really valuable for digging deeper into pediatric topics like this.
Great recommendations, pastthemsra.com and freemsra.com. It's genuinely amazing how far things have come in treating childhood cancers like retinoblastoma.
It really is.
It just hammers home the need for continued awareness, pushing for early detection, and keeping that research going to improve outcomes even further for these kids. Thanks so much for sharing all that insight today.
My pleasure. It's an important one to talk about.